Well, good morning. It's really my pleasure to welcome you to this time where we showcase the Edgren Award winners, and we're grateful to the library for their commitment to providing a place and a space for us to learn all sorts of things from our colleagues. This is a place where Edgren scholars present their research, as well as the Faculty Excellence Award winners, as well as our students who study abroad, and other students who are working on research, or faculty who are working on research. So I'm really glad that you've joined us this morning for this time. I'm Deb Harless, I'm the Dean of the College, and it's my pleasure to introduce Kristin and Hannah and tell you just a bit about their work as part of the Edgren Award. This is a competitive award. For those of you who haven't heard of the Edgren Awards, they're competitive. Faculty and student research teams apply for them, and then they're chosen by a panel of previous winners, as well as the Dean of the Faculty in the college. So Kristin and Hannah's research was selected for summer funding, and they spent their summer working on a couple of projects. And these are in a field that I don't know very much about, so I'm going to read you what these projects were about based on their proposal, and then they're going to tell us in particular about one of these research projects. So the first study was called a pulse trial, and it's an international study based out of Yale, which is very appealing that this has connections to other scholarly institutions really around the world. It evaluates the effects of a web-based cardiac monitoring education for staff nurses on nursing knowledge and skills, as well as patient outcomes. So it's very applied in its application. Hannah and Kristin worked with United Hospital in St. Paul, which is one of 16 hospitals that was included in the study, so it's a far-reaching study. And it was conducted on lead placement to see if the cardiac electrodes were placed where they were placed, and then they did instruction on how to do that correctly. Are you using visuals already?
Yes.
Way to go. So we'll learn more about that. That was the first study, and the second study was called a radar trial. It was an interdisciplinary study of health-related quality of life among elderly people, and in particular, Hannah worked on the data analysis for that study, and they're not going to talk about that one. But as another point before I ask them to present their work, the Edgren Scholarship was established really and named after John Alexis Edgren, Bethel's founder, who in 1871, when he talked about what a Bethel education should look like, he had 4 principles, and one of those principles was what the relationship should look like between faculty and students. And he talked about it as a friendship, that for him, one of the most important things about a Bethel education was the relationship between faculty and students. And so this award was named after Edgren to recognize that really these awards are about students and faculty collaborating. So I'm looking forward to hearing about this collaboration.
Thank you all for coming today. My name is Hannah Wichterman. I worked with Dr. Kristin Sandau this last summer. So, summer 2010 was an adventure. I had the privilege and honor of working with Dr. Kristin Sandau, an experienced nurse researcher from Bethel University. She exposed me to the world of nursing research, mentoring me along the way. I was involved in several studies and completed 6 interviews with nurse researchers across the nation. This was a time of expanding interests, professional growth, and enrichment of my undergraduate education. My time in the, this is an overview of the things I did this summer. So I had a series of interviews with nurse researchers around the nation. I was involved in the pulse trial and attended Alina's basic ECG course, and also was involved in developing education materials for Alina. So my time in the clinical setting was limited due to the pending strike. However, our work was not put on hold. I began conducting a series of interviews with nurse researchers of various disciplines and agendas. I queried them with the following. As an undergraduate nursing student, I am interested in the role nurse researchers and advanced practice nurses have in expanding and implementing evidence-based practice beyond academia. The purpose of these interviews is to develop a better understanding of the conduction and use of nursing research in clinical practice. Dr. Sue Sendelbach is currently the Director of Nursing Research and Critical Care Clinical Nurse Specialist of Abbott Northwestern Hospital. Dr. Sendelbach is the past president of the National Association of Clinical Nurse Specialists. Her current research focuses on cognitive function following cardiovascular events, including open heart surgery and therapeutic hypothermia post-cardiac arrest. This is a highlight from the interview. What unique characteristics do you believe the nurse has as part of your research team? I believe all disciplines look at patients holistically, but each of us brings our own unique science to the research team. Nursing has conducted both qualitative and quantitative research that brings the entire experience of patients. Margaret Home. Margaret Home began her nursing career in Iowa, where she was a critical care nurse at the University of Iowa hospitals and clinics. Dr. Home has described her work as clinical nurse specialist as trying to unravel some of the different clinical problems faced by patient populations, and that being a CNS served as a great breeding ground for research. Currently, Dr. Home works as the Director of Nursing, Research, and Quality at Salem Hospital in Oregon. Highlight from this interview. Congratulations on the several awards, honors, and fellowships. What are some of the highlights of your career? One highlight, I would say, is being selected as American Heart Association Cardiovascular Fellow. That was a year-long leadership fellowship. Individuals from a variety of disciplines were selected to develop an action learning project that would improve cardiovascular health of the community. It took me out of the hospital and thinking more broadly about what constitutes health, what are the determinants of health, kind of getting to the core root. I was able to put together a primary prevention mini clinic where women could come in and do an assessment and do goal setting to improve cardiovascular health. This just illustrates some of the amazing people I had conversations with. Lastly, the interviewee I'm going to highlight is Kim Stevens. Kimberly Stevens first majored in biochemistry, then became a critical care nurse and nursing research project specialist at Renown Regional Medical Center in Reno, Nevada. She is in a study for her PhD nursing research at the University of California, San Francisco. She is also a research associate for the Pulse trial. And a highlight from this interview would be, what unique qualities does the nurse bring as part of the research team? Perception. I think nursing has a different perspective that is unique. I think we as nurses look at symptoms and quality of care and quality of life, and probably less on absolute outcomes, such as mortality. Nurses spend a lot of time with patients as well, so we are able to individualize or provide context to a specific intervention or outcome being measured. Each member of the team has his or her unique background and special purpose for participating. I also conducted interviews with Dr. Barb Hoagland, professor in the nursing department, Dr. Barbara Drew, an investigator on the Pulse trial, as well as Dr. Marge Schaefer, another professor at Bethel University involved in public health. I am also pleased to announce that my articles have been accepted for publication in the Nursing 2011 Journal.
Wow, congratulations.
Very exciting. Okay, so now I'm going to segue into ECG, which is what I spent a lot of time on this summer. For those of you who are unfamiliar with ECGs, they provide a graphic representation of cardiac electrical activity. The cardiac electrical currents are transmitted to the body surface. Electrodes are placed at specific anatomical points and are attached to cables connected to a monitor. Okay, so there are various components of the ECG. The P wave represents atrial depolarization. The QRS complex is ventricular depolarization and atrial repolarization, and the T wave is ventricular depolarization. Here is an example of a typical waveform. You can see the P, QRS, T. And here is a normal 12 lead. There are actually 12 different views of the heart. For example, leads 2, 3 and AVF view the inferior portion of the heart. If there is evidence of ischemia in 2/3 of these leads, that would indicate a lack of oxygen to the right coronary artery that feeds the inferior part of the heart. Thus, an angioplasty may be performed to try to press open the plaque in the artery. This is an example of a 5-lead. These are commonly used on telemetry units in the ICU and also in the ED. The point. Variations in these complexes can indicate pathological processes which warrant prompt intervention. So, what is ischemia? Ischemia is a lack of oxygen to body tissues. Ischemia in the heart tissues can lead to myocardial infarction or heart attack. The ST segment may become depressed or elevated. Okay, so more specifically, ischemia on the left is an example of a T wave that has become negatively deflected, rather than maintaining a normal positive deflection. On the right is a telemetry strip showing ST segment depression. Both hearts are experiencing abnormal depolarization of their ventricles because of the lack of oxygen, and ischemia is ensuing. Injury and infarction. This is when it becomes a little more serious. This slide demonstrates a patient who is experiencing a later sign that ischemia is actually resulting in injury. There is potential cardiac death, thus an MI, or myocardial infarction. If the patient has symptoms and this ST elevation shows up on a 12-lead, the patient will be assessed further with blood draws to assess for damage, such as indicated by troponin levels, and may end up in the cath lab for an angiogram. However, ST changes do not always show up on the 12-lead because the changes may be transient. They may come and go. A static 12-lead only gives a result for about 10 seconds. Studies have indicated that 25 to 70% of ischemic events are actually silent, meaning patients may not perceive them as chest pain and may not communicate them to clinicians. At this time, I would like to invite Dr. Sandau out to further elaborate on this topic.
Thank you, Hannah. As Hannah was mentioning, one of the things that some of the more recent studies have shown are that you can get your 10-second 12 lead and it can look great. But then when you leave the patient then for observation to see, are they going to have another episode of chest pain like they had, at church or at home, you can miss any ST changes if you're not continuously monitoring them, as if you're using a video recording rather than a camera. So a 12 lead that is being passed around is about 10 seconds, and continuous recording would be done by the nurses by telemetry. And so American Heart Association came up with some guidelines with their experts reviewing some of the studies that were available and said absolutely we need to be using continuous ST segment monitoring for patients in certain categories, those for whom we're ruling out myocardial infarction, those undergoing major surgery, for example. As we talked about this, at Alina, we found some of our hospitals do it and some don't. And so we're curious, well, why? Are people not aware of the guidelines? What are the barriers to instituting them? So this was some of the work that we did a couple of years ago then with actually Joel Fredrickson helping with the analyses here from our psychology department, as well as a couple clinical nurse specialists from Alina, Sandau, and Karen Doran. So reality check. We've got American Heart giving us these guidelines. Now how many of us are actually using them? And in a study that we took, we randomly selected 200 cardiologists from across the nation, and we found that less than half of them were even aware that there were cardiac monitoring guidelines published from the American Heart Association. And then we found out that of the responding cardiologists, less than half, a little less than half, were at hospitals that had a standard of practice for using continuous ST segment monitoring for patients who came in with chest pain, for example. So we asked about what were some of the perceived barriers. Why? You know, if you're aware of the guidelines, why wouldn't you be using it? And we had actually we had 61.5% that were concerned about false positive alarms. You know, we have enough alarms going on in the hospital. Alarms are going all the time for different kinds of problems, and so we don't need extra ones that are not correct. Another of the concerns was lack of understanding for the technology by nursing staff. Wow, that's where we can come in. We can help with that. And so that's part of what Hannah was working on, to provide some additional education on that. And then thirdly, extra phone calls. Physicians and Ps are busy enough to not wanting to get extra phone calls for alarms, for example, that were not accurate, or for things they didn't understand. So, so this gave us kind of a good understanding of why they weren't being implemented. And then, so some of our work now is on research translation. There's some studies that show that it can take 7 to 14 years for research to be put into practice. That's a lot of delay time. Why is that so long? So there's several of us interested in research translation then. How can we get the research into practice without that long term in between? So that's what I'm currently focusing on now. And Hannah's been really helpful. She's really good with getting pictures and graphics together for some of the educational materials. So measuring the QT interval. So we talked about ischemia monitoring, and then there's also an area that American Heart has guidelines out about, and that's being aware of lengthening QT intervals. So the QT interval is prolonged by certain medications. And so this is showing you where the QT is, from there to there, and on certain medications this can become too long, and if it's too long it can be very dangerous. And this is a patient strip where they began to have some changes in their heart waveform after starting on a QT prolonging drug. Their QT interval was longer than 0.5 seconds, and then eventually they went into a very dangerous kind of polymorphic ventricular tachycardia. And you can see that first they're upright, and then they flip downward, and then they flip upright, and this is called a torsade de pointe. And this can be for patients that have too long QT intervals. Does it happen very often? No, it doesn't. When it does, is it potentially deadly? Yes. So trying to see if we can catch prolonging QTs when someone has started on a drug in the hospital that will prolong it. Trying to notice that, having a protocol for measuring so we can prevent that from happening. So it starts with identifying the risk factors and QT prolonging drugs. We have a list of those, especially if they're given in an intravenous route. So, for example, intravenous Haldol is given for patients that are neurocognitively kind of wild, let's put it. We sometimes give to help them calm down in the hospital. If you put that on top of someone who has bad renal failure and is a little bit older, that's going to be a very deadly combination. So taking a look at the risk factors. So again, American Heart does have these guidelines, and we are working as a group then at Alina to try to figure out how can we make this happen so that we can not just rely on the pharmacist to say, oh, that's a QT prolonging med and it's added to someone who's already on a potentially QT prolonging med. Trying to say, you know, let's get the nurses involved in some of this monitoring then. It turned out we don't really have a system in place to prompt nurses to do QTC monitoring. So your QT interval will vary depending on your heart rate. So if your heart rate is really slow, that's going to stretch out the QT and make that longer. So we need to have a system to be able to calculate the QT so that it's not dependent on heart rate. And here is the formula right here. This Bazette's formula has been around a long time. Well, those of you who know nurses work in the hospital, maybe you would agree with me, we don't have a whole lot of time to find a calculator and put in these numbers and find the square root. And so one of the things that we're working on now is trying to get the Alina computer people for computerized charting to put this formula right into the computer. And it's there, but right now nurses have to actually add this whole section manually and then use R-to-R interval. And there's a lot simpler way that if that could automatically be there, and the nurses could just add the heart rate and the QT, and the formula would self-correct then. So that's what Hannah's been able to see, that I put in this request in July, and here we are in November, and it's still going through various committees. So this is a great example of why we have barriers to putting evidence into practice, but it's going to happen. So we're going to continue to address barriers. including avoiding false alarms and so that the cardiologists are not afraid of using this technology, this added technology, working with biomed and clinical experts to be able to make it really user-friendly for the nurses and have existing protocols available. Nurses that had an introduction to ECG class 15 years ago, that's not enough. And there isn't a real great system for having paid education for nurses to advance their knowledge, and it needs to happen. Cardiac monitoring is getting so much more elaborate, and so we need to have ongoing. So Hannah's going to help me as well, whether she likes it or not. She kind of signed on for a project that extends past the summer. So she's helping me with some of the second quarter online education learning for Alina nurses then regarding QT monitoring with this new system then. Yeah.
All right. So I'm going to talk a little bit more about the PULSE trial here. This is a photo taken at a workshop at United Hospital last spring. Dr. Barbara Drew, a person I did do an interview with, is one of the principal investigators of the PULSE trial. Overview. PULSE, what does it stand for? Practical use of the latest standards for electrocardiography. It's a $4 million study funded by the National Heart, Lung, Blood, and Institute. It's a 5-year, multi-site randomized clinical trial to test the effect of implementing cardiac monitoring practice standards. There are 16 hospitals in the United States and sites in Canada, and Hong Kong. All right. And again, it is based out of Yale University and the University of California, San Francisco. This is the PULSE abstract. Monitoring practices for heart rhythms are inconsistent and inadequate. Practice standards have been published by the American Heart Association, as Dr. Sandau was just explaining. Purpose for this study: to test the effect of implementing these standards on nurses' knowledge, quality of care, and patient outcomes. Expected increase in knowledge of nurses will lead to enhanced quality of care and improved outcomes for patients. ECG Monitoring Education and Strategies to Implement and Sustain Change. There are 4 modules: Essentials for ECG Monitoring, Arrhythmia Monitoring, Ischaemia Monitoring, and QT Interval Monitoring, which you now know a little bit about. And they expect that improved ECG monitoring will result in more accurate diagnosis and more timely treatment, which will lead to better outcomes for patients. This slide is just to show the collaboration between Bethel University and Alina. Okay, so the Edgren contribution to the PULSE trial. One aim of the PULSE trial is to improve nurses' knowledge and skills in ECG monitoring. An electrode placement audit performed in the spring demonstrated acceptable accuracy for the 4 limb electrodes. So we kind of talked about that. 5 leads. You have 2 arm electrodes, 2 leg electrodes, and then a bead. So the audit performed in the spring revealed accurate limb placement. However, only 28% of the time the V lead, or V1, was accurate.
These were okay, but this one was a problem, whether it was placed here, 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 or here.
Yeah, and one of the, with education on lead placement, often people are given regions or not really the anatomical markers, and that does have a huge effect on what you're seeing on the monitor. So, we provided coaching on electrode placement using anatomical markers and tested coaching via pre- and post-audits. Okay, description of the study. So, baseline PULSE data provided evidence that quality improvement for accuracy of the chest V1 electrode placement was a priority. We performed baseline audits on 10 patients, demonstrating initial acceptance of inter-rater reliability and then discussing until 100% agreement was reached.
So Hannah and I agreed on correct placement.
First, we had to establish that.
Yes. She had to test me to make sure I knew what I was doing. We conducted baseline audits of all patients receiving continuous ECG monitoring. Our population was 72 for baseline. Over the next 3 weeks, I coached nursing staff with an interactive poster consisting of a chest diagram and Velcro electrodes. Staff were asked to test themselves, revealing placement issues that could be immediately addressed. Teaching was tailored per individual. For example, some did not want to test themselves. And coaching occurred individually or within a group. As Dr. Sandau was explaining, hospitals are a crazy setting, so it's hard to take time away from people. So sometimes I would catch them at change of shift and go into their report and say, give me 5 minutes, and I was always well received, which I was very grateful for. And our follow-up audits, so our post-intervention audits, our population was 77. We performed to assess the effect of minute coaching. This isn't actually a patient, it's one of the nurses at United Hospital.
She looks really
Yeah, she looks really happy to see me. So just to kind of show a picture of what it looked like going around assessing the electrodes, you'd have to take the patient's gown off and look at the placement on the chest. And here is an example of minute coaching. So there's the poster there and addressing the placement. Okay, let's talk a little bit about baseline data. As I said, in the spring, there was an audit conducted revealing 28% accuracy. When when Dr. Sandau and I did baseline, we found that 50% of the time V1 or the chest electrode was being placed incorrectly. So, the significance. This poster over here, there's a case study from San Jose demonstrating that this V1 was placed an inch below. What this reveals is an aberrancy or supraventricular tachycardia. When the electrode was placed correctly, so in the fourth intercostal space, as it should, it revealed V-tach, which is a life-threatening rhythm. That was kind of the scare tactic I would use with some of the nurses, just to kind of reiterate it is important where we're putting our chest leads. With the intervention, I conducted in-service during several shifts on various units. I coached on telemetry units, in the PACU, in the ICU, and in the ED. This time consisted of brief overview of the anatomical landmarks for lead placement, as well as alternative placement for challenging patients, such as those with a pacemaker or women with large breasts. Nurses had the opportunity to test their skills on the interactive poster, review the case studies, and receive handouts to place near the monitors. And post-intervention. So, this might be a little hard to see, so I'm going to go to the outcomes slide here. But we saw significant improvement from 50% to 65%. Correct. So chi-square analysis showed significant improvement for placement of the V1, with accuracy improving from 50% to 65% after 3 weeks of minute coaching. Some additional work was developing education materials for Alina. Can't see these very well, but the first sheet is a list of those QT prolonging drugs. Dr. Sandau and I collaborated on developing these, and you're hoping to have them available in the spring, I believe.
As mandatory second quarter education.
Yep. The second page are various materials from the PULSE trial demonstrating lead placement, which leads are monitoring which coronary arteries, Torsade de France, etc. Again, I was involved in handing out pocket cards for CNAs because the CNAs do place the electrodes after maybe they've given a patient a bed bath or whatnot. And the response I would get from a lot of these nursing assistants was, wow, I was only ever given just a diagram that said, here are some regions where to place these. I had no idea that it needed to be to the right of the sternum. Often it was being placed right on the sternum, and you don't want your lead to be right over the bone. Brochures that were a bit more extensive for the nurses. And then this is just an example of the diagrams that were posted near monitors and showing actually what would be a 12 lead for the correct anatomical positions. So, and I also attended Alina's basic ECG course, learning the basics of cardiac monitoring and rhythm interpretation. This was an enriching experience and served as an excellent supplement to the work I was doing in the clinical setting. So, conclusion. Following completion of my BSN, I plan to pursue graduate nursing studies in DNP, CNS, or PhD program. My interests are in both professional development and research. I am particularly interested in evidence-based practice and clinical pathways as a means to improve patient care. I hoped as an undergraduate to have the opportunity to participate in a study project with an experienced researcher. I enjoyed many aspects of this mentorship, as well as the data collection and analysis. I believe my educational background and experience at Bethel University have adequately prepared me for entrance into work in an adult healthcare setting. Dr. Sandau's involvement in nursing research and undergraduate education exposes her students to the vast array of nursing functions. I have appreciated her insight, teaching style, and experience for practicum. We make a great team. I share her passion for research and nursing. And I would also like to say a special thank you to Bethel University and the provision of the Edgren Research Scholarship. Thank you.
Like you to ask all kinds of very tough clinical questions about just I should have looked some up. No, actually, any questions or comments we'll field together.
So how were you received as a student coming in and telling these RNs how where to place their things?
Yeah, I was well received. I was surprised by that. I've had clinical experiences in which nurses could not be less interested in having a student. But no, I was very well received. A lot of them asked questions, asked a little bit about myself, kind of what are my interests in nursing. And those who weren't interested, they just stayed away. They just kind of ignored you and you ignored them, and yeah. It was all good.
What's the title of your article?
Well, there's various titles. Depends on spotlight on nurse researchers. We're kind of in the process of thinking of catchy titles for the various nurse researchers that we highlight. What did we come up with for Dr. Sendelbach? I can't even remember.
I don't know.
Yeah, I don't know.
But it'll be whatever their focus is that came out of the interview.
So there's a series of then.
We're hoping for a
6.
series. The first one was accepted and will be hopefully mid next year, and then we're hoping they'll let us do a series for the others. So we've got 2 more that are polished, and another couple more that will be submitted a little later. The particular journal that we chose, Nursing 2011, is more of a casual readership, less research oriented, and so we thought the interviews would be a really good way to get that audience a little more interested in kind of putting aside the shroud of mystery. What is nursing research? Just a face of a smiling real person and what they do in real life.
Yeah. I think nursing research is very ambiguous. for a lot of people. So
Because it can cover so many areas.
Exactly.
It can be public health or critical care, or as Kim Stevens is studying now on a cellular level, pain receptors to see how women with breast cancer respond differently to pain. Why some have it and some don't. So there's such a variety from the cellular level to the hospital to public health and prevention.
yeah, so I had conversations with nurse researchers in various disciplines to get a better idea of what nursing research really does consist of. You know, we're always talking about evidence-based practice, and it's well known that our med-surg texts are not going to be static, but healthcare is so dynamic, and so nursing research plays a major contribution to the improvement and the quality of care for patients. So.
I have a comment to make. You know, I have to say that from what you've just said, I hope this research will make a big impact in healthcare facilities, because I used to work on a cardiac monitoring floor, and I have to say this, I was trained once, I took a class on the EKG, and that was it. The rest I was left on my own to learn on my own, and maybe like even to learn on my colleagues and how they practice the EKGs. But honestly, from the results, from the side effects, I hope this research will bring out a lot, will make a large impact on the nurses and the physicians also on how to monitor EKG, how to monitor clients who are on EKGs.
And that was a very similar story to some of the comments I received from nurses and nursing assistants on lead placement. They said, I was just told regions. And I attended the basic ECG course, and in the manual or in the book for that class, they show the 5 lead on a sketch of a chest, but it doesn't have any ribs. So it's just, again, the regions being revealed. So I was involved in developing supplemental material that will hopefully go into publication for a new or a revised.
We're actually revising that basic ECG manual. So yeah. So hopefully there will be some budget implications. I mean, that would be my dream, is that, nurses cardiac monitoring education will be ongoing and paid for, not just an intro class at the start of your career, 15 years ago.
So is there no expectation that nurses continue their professional development?
Yes, there are mandatory, to renew your license, but the topic areas are not dictated.
Oh.
Yeah. So hospitals will generally have mandatory education, but they're under so much pressure from the Joint Commission of Accreditation and CMS for regulatory education that it mostly consists of meeting those requirements rather than professional development and cardiac monitoring. So it depends on the hospital you're at, but the PULSE trial I think will help because it is such a large multi-site study that I think that will hopefully help so that other educators around the nation will be able to say, here's the standard. It's not here anymore. It's actually up here. Any last questions or comments?
Did you get the feeling that anybody was alarmed in these places, that when you were telling them that they had been incorrectly doing this and the impact to the patient?
Yeah, and some people were very surprised. That case study is, well, first of all, most people are placing them too high and not too low, so that's showing lead placement being too low, and it is an extreme example. But no, they were very shocked. They kind of were like, wow, I had no idea that where I put my B lead really has implications for what's showing up on the monitor.
So Hannah would teach them, how to feel for your for the bony prominence of your sternum,
The manubrium.
if you that your angle of Louis there, and when you feel to the bottom of that, and then you slide over, and that would be your second intercostal, and you need to go down 2 more. And that would be your 4th. So that's the correct way. Instead of just using landmarks, just like regions, you need to actually palpate to find the correct placement. And that's what they weren't being taught. So, yeah. And then the next stage in my dream world here would be that the nurses could think outside the box and not just always place that there.
that depending on what they were monitoring for, if they were looking, for example, at the circumflex artery on this side of the heart, they would consider placing this lead over here. And then they'd have a more accurate visualization of what's going on laterally on that part. So we got a lot of work to do. So Hannah's got to go to grad school and, and help out.
You have to keep her busy. Let's thank our presenters.